Okay, I'm gonna hit record now.
Love
But
that. Okay.
honestly, I've been so looking forward to speaking with you. One, because
Oh,
I've heard so much about you and I have a lot of friends that go see you, but
thank you.
also because I feel like because of my health journey, I have such a love for gynecologists, such a love and admiration.
Fantastic.
And I feel like a lot of women have this fear, like there's such a barrier that lives within, you know, women and their comfort of going to the gynecologist. Like there's
See
so
a
much taboo.
gynecologist.
There's so much, I don't know, like culture puts a lot of barriers on feeling
Yes.
discomfort. And I just want to help remove those barriers, or at
It's
least get
brilliant.
women the information and the education and the advice straight from a gynecologist.
It's brilliant,
And
honestly.
just yeah, remove those barriers, you know?
I think this is excellent, Emaan, honestly. The word gynecologist used to almost be a dirty word in 20 odd years ago, where if you were going to see your gynecologist, you really wouldn't tell anybody. You would just very quietly sneak into the office and get on with what you need to have done. But this is wrong, really. And
Yeah,
thank you for this wonderful initiative. It's all about demystifying, and
right,
it's all about just breaking it all down. Because if you were going to see your dentist, or if you were going to see your orthopedic doctor, you could shout that out on a mountaintop and no one would say anything about it. If you're going to see
right.
your gynecologist, everyone is like, oh,
Shame.
oh. And that's got to go, and that's got to go. It's
Right,
completely, we are holistic, we are human, we have all our functions going, and we can't separate reproductive health from life. You really just
right.
can't. It's part and parcel of it, actually. So yeah, thank you very much.
Of
We have
course.
always regarded ourselves in obstetrics and gynecology. Sadly, it's changing. I have to say it's changing, but we were always the second cousin, or the third cousin, or in a department where the cardiologists would be out there, the orthopedics would be out there, internal medicine, and then the gynecologist would just be at the back seat.
Like, look at me, look at me.
Exactly. That has to change. That has to change.
It's funny because I actually don't have a general doctor. I only go to my gynecologist, which
Amazing.
I have to come see you soon. I mean, I'm sure
Amazing.
you've
That's lovely.
heard or read all my or
That's,
seen all of our
I
videos
have
on
indeed.
PCOS, and I would love to come see you. So
I'd love
I'll
to
be
see
booking
you
an
too.
appointment soon. But
Anytime,
yeah,
anytime.
my primary doctor for the last, I don't know, 6 years has been a gynecologist. So
That is amazing. That is
yeah,
really lovely, actually, in the sense that that it's women's health, and that gynecologists, good gynecologists will look at you holistically. If of course our focus is going to be reproductive health, it's going to be women focused, etc. But we absolutely have the ability to refer, to make sure that our women are healthy. And that means if you have a cough or a chest pain or whatever, we are going to make sure you see the right people to get that
right.
sorted out, knowing fully well that this is going to affect your reproductive health. If you have mental health issues or there are concerns, we would get you referred to see the correct person, so that that aspect of you is also sorted out, and that also will affect your reproductive health. And so what you're saying is really very important, and it's a really big message, actually. And good on to your gynecologists to be able to make sure that you are the only doctor. They are the only doctors you get to see, which is amazing. Really, really,
Yeah.
really amazing.
I know you only have a limited amount of time. I do have a bunch of
Yes.
questions for you, but
No worries.
before I dive into the questions, I'm more so
Yes.
curious, like what led you to want to get into gynecology, and how
It's
did your
good.
journey begin?
Yeah. Oh, it's so lovely. Okay. So, it's a fantastic question. Love to share it. as you know, I've been in this field, obstetrics and gynecology, for 28 years, actually. I started my training in 1991. And I did my original training, my primary MBBS degree, which is when you'd qualify to become a doctor, at the University of Lagos in Nigeria. And it is a large university teaching hospital. It's our premier university hospital. And it was the best 5-6 years of my life, definitely. And actually, I became a gynecologist when I was a year 3 medical student. I knew I was going to do gynecology, primarily because I had one of the best teachers. I had one of the best tutors. It's actually, he was a man. His name was Professor Giwa Osage. And he was just out there when it came to empathy and when it came to understanding women and understanding women's needs. We always used to say he was born in the wrong body really. He should have been female. But at university, we have a clinical year. We have 1 year where we spend, in fact 2 years, where we spend a lot of time with patients, and we do an OB-GYN rotation, which is 3 months. And it was, as I said, one of the best times of my life. I fell into it just, it was a glove. I fitted into it and I never looked back. So I don't really know. Even when I became a consultant and when I was, when I interview young doctors and I ask them, what are you planning? And they say, I'm not so sure, Dr. Mariam. I'm going to wait a little. I can't understand it. But my decision was very early, very, very early on in my medical career. And then when I graduated, I went to the UK, as I said, in 1991. And I began my postgraduate training in obstetrics and gynecology. Again, I started at King's in London and found it's a busy, busy teaching hospital, loved it. And then I rotated throughout to St. George's Hospital, another large hospital in southwest London. And then I got the so-called training specialty post in Northeast Thames Deanery in London. And then I spent the next 13 years actually training. I was training flexibly. And I loved it. Every single hospital rotation I did, I loved. And I really only found my calling probably much later in my career, when I was just about to become a consultant in the UK, when I realized that definitely women and children, high-risk pregnancies, preconceptual counseling, so looking at women before they become pregnant, cervical screening, women's health was very, very important to me. And the rest is history. I became a consultant in Barnet and Chase Farm Hospital, NHS hospital, and spent about 7 years there. And I responded to a random email inviting me to come to the UAE to help to train Emirati doctors in obstetrics and gynecology. And I was at that point in my life where there was so much happening to me that I thought, okay, I was going to take a break from London and the UK and everything else. And I came out for a 2-year sabbatical, which then turned into 9 years in the UAE. And
that's everyone's
here I am.
Story. 2 years.
Yeah, just love it.
7 years later.
Lots of people say, Dr. Mariam, do you actually have a life outside gynecology? I do, but I just love it. I do not separate obstetrics and gynecology from my life. I really don't. I look at it as one and the same. I'm just as passionate in my field as I am outside. And I love it, really.
Oh, that's incredible. Like sometimes you realize that you live your purpose, yes. and it's when your job doesn't feel like a job, it feels like you're really living out your purpose. I feel that for me.
Exactly, Emaan. That's exactly it. Actually, I was lucky. I'm very grateful, to God to at least have shown me that, because not everyone not everyone finds that calling so early, but I did. But before medical school, I wanted to be an engineer, or I can't remember what I wanted to be. And my father said, no, you are not going to be an engineer. You are going to be a doctor. And he filled it out. He filled out my form.
Yeah. It sounds
Thank
like
God he did
Middle
that.
Eastern, Nigerian, the parents, they're quite
You know
similar.
what they're like. Very similar cultures.
Right. Well, thank you so much for sharing your
No
journey
worries.
with us. It's
No
incredible,
worries.
and we're so lucky to have you. And we're so lucky to have you answer some of these questions. So we, a couple of times now, we've put out the question, what do women want to know from a gynecologist? So I'm just going to go through a couple. Would love to hear your advice. A lot of these have to do with contraception, menstrual cycles. So I'll just go through them, and then you can share your advice for us. So the first is, what could it mean if your period isn't regular? If you're not having a normal cycle month to month?
Okay. All right, it's a really good question, and it's one of the commonest reasons a woman will walk into a gynecology office to tell you that I have irregular periods. Now, physiologically, and this is in the normal setting, when you start having your periods, we call it the menarche, that happens at around 11 to 14, can go up to 16 years. Up until when you are 18 years, you're not going to have regular periods, usually. Menarche is generally a period where the woman is not ovulating on a regular basis. We call it anovulatory, and the periods therefore are not always regular. So irregular periods at that point in a person's life is actually normal. When we get to age 18 to 35, we expect that our periods are going to be nice and regular. We expect that at least 9 times a year, we are going to be releasing an egg. And we're going to be able to trigger a lovely little pattern, the menstrual cycle pattern. I'm not going to go into all the complexity of it, but the menstrual cycle is an amazing cycle which runs like clockwork. It's meant to run that way. And you will not believe little changes, tiny little changes to that cycle can completely dysregulate the periods. But in the absence of all of that, we expect 18 to 35 to be the best times. And so if something happens, we need to find out why. And that's what we're going to talk about. Again, I just want to say physiologically, when you get from 35 years on all the way to the menopause, which is around 51, the periods generally start to become a little bit more and more irregular. And this is normal. It is due to ovarian resistance. The ovaries are getting a little bit stubborn. They've spent all these years releasing eggs,
working hard,
running this cycle, and they're really tired. And they say, look, we're not going to listen to stimulus anymore, and we are going to take breaks. And so they start taking breaks, and the woman starts to get irregular cycles. That's actually normal. It's not completely abnormal. The problem is at that time in a woman's life, between the ages of 35 and 51, there can be many other problems that can happen other than just menstrual dysregulation. And so we still encourage women, if you notice a change in your menstrual pattern, you got to come in. So that's out of the way. And the commonest cause really are all the anovulatory patterns, all the things that, so thyroid, women whose thyroid glands aren't working properly. Prolactin, which is the milk hormone that comes from, the popular word is the milk hormone. It comes from the pituitary gland in the brain. That can sometimes be either too high and cause dysregulation. Also, all the conditions that make you not ovulate, like polycystic ovaries, like premature menopause, premature failure, like women who are taking medication, high dose steroids, for instance, they may not regulate, have regular menstrual patterns. But all of this is fixable. All of this can be sorted. And so the advice is always, it's really patterns that you need to be looking at. The menstrual cycle can be 20 days apart. In other words, there will be some women who normally will have 2 periods in a month, but they have shorter cycles, and that's normal for them. And you will also have women who have cycles that are every 45 days. That's really the upper limit of normal. And those women will look as though they skip patterns or skip a month before they have a period. So you have to study your pattern, look at what your pattern of period is and cycling is like. And if you notice a change in that menstrual pattern, by all means, come in and get checked out.
That's great. I have the most irregular periods, whether I'm on birth control, not on birth control, like it's all over the map. But obviously I have PCOS and polycystic ovaries. So
you got checked. You got checked, absolutely.
I definitely did. Okay, next question. This is one that has come up a couple of times. As women are deciding to come off of birth control, maybe they want to start family planning, or maybe they want their body to start regulating their hormones naturally. What are some things that you would recommend for women that are coming off the birth control pill?
It's an excellent question. And it's a question that we sometimes don't address when we are very happy to put you on a pill and we say, oh, take the pill, it's a magic drug, you're going to go away, you're going to be fine. And we forget that it's finite, it's not infinite. They're not going to stay on the pill forever. Just a quick mention about the pill. As a lot of our viewers will already know, the pill actually takes over your cycle. The simplistic way to look at it is that the pills put your ovaries to sleep. They will stop your ovaries from releasing their hormones, from releasing eggs every month, and they virtually are asleep. So what is making you bleed every month is actually not your hormones, but the pill. So imagine if you have been in a state of dormancy all that time. Someone gave you a sleeping pill, Sleeping Beauty, and you were put to sleep for X amounts of months, X amounts of years. When you wake up, you are not exactly going to suddenly say hi and go off to the supermarket or do something really, exciting. It's going to take you a while. It's the same thing with ovaries. So particularly women who've been on long-term combined oral contraceptive pills, when they come off it, two things happen. One is they've actually forgotten what the menstrual pattern, or they don't remember what their previous menstrual patterns were, whether it was heavy and painful and uncomfortable, etc. Maybe they do, maybe they don't. But when they stop it, they are going to notice that the first one to two cycles, maybe even up to 3 cycles, just take them by surprise. Either they are scanty and infrequent, or they are heavy and prolonged. This is not necessarily abnormal. It is really a situation where your ovaries are waking up, realizing, look, hey, I've got to start, chugging out estrogens, progestogens. I've got to respond to luteinizing hormone, follicular stimulating hormone. These are all the hormones that are acting on your ovaries. And it takes a while. So my advice for women who are coming off the pill is, 1, expect the worst, I'm afraid. Expect that your periods may not be the same. Okay. They may be heavier, they may be scantier, and therefore you've got to have something that you're using to prepare. For instance, if you should really have some type of non-steroidal anti-inflammatory preparation, like Ponstan, for instance, for women who previously had heavy periods and are coming off the pill. Make sure that when the periods are starting, you've got some help, some tool to make sure that you're not going to go back to those heavy, horrid cycles that you had before, say for the purposes of having, if you want to become pregnant. The best way is to use something like a non-steroidal anti-inflammatory drug like mefenamic acid. And if it is scanty and irregular and infrequent, then just give it a little bit of time. Give it 1, 2, maybe up to 3 months. But after 3 months post coming off the pill, if the cycle has not regulated, then I'm afraid, again, you're going to have to come back and see someone like me, who then just checks to make sure that you are fine, that your hormones are normal, and that the ovaries have actually woken up and that they're doing what they need to do. And there's a last thing I want to just quickly mention to your viewers about coming off the pill. And that is, pills are meant also, although they keep the ovaries asleep, you look at them as a training pattern. Your body is actually, in the last months or however long the woman has been on the pill for, has been trained to bleed after 24 to 28 days. And there is also this group of women who they come off the pill who will actually continue to cycle normally. So it's not all doom and gloom, I have to say. There are some, about 30% of women, who will continue to cycle very nicely after they've come off the pill. And those are the lucky ones, actually.
Yeah, the very lucky ones. I know for me,
Yes.
it was quite a challenge. Obviously, I've
Yes.
had PCOS for a long time, and I
For a
think
while.
my body just went haywire. My symptoms
Naughty. Yes,
really,
yes.
really went out of control. And it's
Naughty.
unfortunate that a pill like PCO or a pill like birth control, it
Yeah.
hides or it masks these
It
symptoms.
does. It does, because it's actually just taking over your cycle. That's all
Right.
it's doing.
Right.
And in the hope that in the hope that one, it will the body gets trained that way, or two, in the hope that whilst you're taking the combined oral contraceptive pill, you're also using other measures like lifestyle for PCOS, like glucophage sometimes, which is an anti-diabetic drug. It's a sulfonylurea, but it's extremely effective at helping with insulin resistance. And yeah, coming off the pill, it also depends on why the woman actually used the pill in the first place. That will determine how difficult it is when she comes off it. So if the pill was only used just for birth control, then coming off it is usually quite easy.
Yeah.
But if the pill was used for other reasons like polycystic ovaries, PCOS, sometimes even if the pill was used for other hormonal imbalances, then coming off it will usually return the woman back to what she was if you haven't used anything else to correct it.
Right, right. Okay, I could go on and on about this topic, but we'll come back to it.
We'll move on.
I'll come visit.
I talk a lot as well, Emaan.
No, it's great. It's great. I love this. I love this. It's so important. I feel like a lot of this information, it's so hidden behind closed doors. So I think it's great for women to hear it all. So please educate us.
Fabulous, fabulous.
Okay, so the next question, and this is something that I think, it's a question that we've heard a lot, and it's more so around, does someone need to go to the gynecologist if they are not sexually active? And I'd love to hear your opinion as a doctor, as a gynecologist, as to, what age should a woman start to see a gynecologist? What do you recommend for women that are not sexually active but still want to know, about their body? What is your advice around that?
Absolutely, Emaan. It's a fabulous question, because gynecology is not just sexual and reproductive health. It isn't just about that. It's about a lot of other things. And remember, we started the talk by talking about what happens to women throughout their lives, throughout their reproductive tract, their reproductive life. We start at menarche. In fact, we probably start before menarche, but I won't go there because that's sort of a fine line between pediatricians and us. But, to be honest, from the moment a child, a young girl, starts her periods, so that time could be, the commonest is usually between 11 and 12 years old, but it can go from 9 years old to 16 years old. We tend to see young girls to help them through this pretty difficult time where they don't understand what's going on. Their parents, their mothers, sometimes themselves don't understand or didn't have the tools to deal with what's going on. And so coming to a gynecologist, demystifying it all, realizing that, it's not a big deal, this is natural, is really helpful. Also, in that age group, precocious puberty is a big issue, and it's becoming more and more of a big issue where younger girls are getting secondary sexual characteristics, so breast development, axillary hair, pubic hair, and parents are so frightened that, oh my God, my child has become, curvaceous. What am I going to do? This is normal. They come, they see us, we reassure them. If we feel that indeed it is precocious, and indeed if we feel we give them education, and we do some tests and we reassure. When you come into the age group 18 to 35, it's a very important age group because women are now confident in themselves most of the time. They don't don't have to be married. They don't have to be sexually active. They can choose not to be married, and they can choose not to be sexually active if they choose, if they want to. You know, it is a woman's choice. That is precisely the time where women need to get into the culture of seeing a gynecologist once a year. When you come into a gynae office, there are lots of things that we look at. We look at the history, not just the gynae history, but also the medical history, so the background. And it allows us to keep women safe, keep women healthy. Many things happen to us in gynecology. I can tell you, from diabetes to hypertension to more specific problems that can affect rheumatoid arthritis. And interesting enough, we're seeing more and more of that effect. So there's a condition called antiphospholipid syndrome, which is a very big word for just saying that women carry atypical antibodies and proteins in their blood. They don't know it. They're not married. They're not sexually active. They don't know what's going on. They only begin to understand once they get married and start having, say, recurrent miscarriages, or have a blood clot, or have something that is really quite risky for their health. Now, all of this lovely information can be picked up if women who are not married, not sexually active, just get into the habit of coming in to see a gynecologist. And when you come in to see a gynecologist, it is not a horror. It's not a house of horrors. Honestly, we don't pull out our speculum and do some horrible things to you. Never. We don't do that. It is not like that at all. We are very respective. You know, we do respect, you know, cultural preferences, women's choices. There are some, in fact, I grew up in London. My early years were in London and in Moscow before I came back to Nigeria. So, you know, different cultures will accept different types of examinations. And we are fully respective of this. And there are many ways of being able to assess a not sexually active woman who does not want to have an internal examination, and give her a very good assessment of what she's like, not just gynecologically, but also medically. So I can't, you know, I'm so glad you asked that question, because, you know, gynecology has always been confused with sexual health. In fact, sexual health is actually a subspecialty in my field. Yeah, you go and you train for 3 years or 4 years for sexual health. Gynecology is much bigger. It's a much bigger field. It encompasses, you know, not just reproductive health, but also, you know, the health, the complete holistic pattern, the whole health of the woman. So, you know, you pick up things that, of course, might affect her from a gynae point of view. For instance, if she came and told you, oh, look, my auntie, my mom, my 2 sisters, both were diagnosed with breast cancer under the age of 40, I'm worried. Of course, that's a very important sign. You will definitely be looking at that. You will be advising her and telling her what is safe for her long before anything happens. So if there's one big message that can come out of this, please come to a gynecologist long before you're married or sexually active. It's so important. We are not just looking at sexual health. We are looking at so many more, so much more.
Right. I think it's also a great and safe space to learn about the sex topic. I know that that's definitely a fear that some parents have, is like, how do I talk to my children about sex? And I think it's a great place at the doctor's office to learn, you know, as you're growing into yourself.
You are so right. It is so right. You remember we alluded to this, where, you know, the young lady has issues, gynecological issues, can't talk to her mom, or talks to her mom but says it very superficially. And mom's like, I don't know what to do. I'll take you to see Dr. Mariam. And it's a great safe space. It really is, to have it all out there, and to you know, it's amazing how many and sometimes this doesn't just happen with moms and daughters. It can sometimes happen with sisters. I see it a lot with sisters, 2 sisters coming in, one trying to support the other and saying, look. Sometimes I see it with friends, 2 friends coming in. One friend has the problem, the other one doesn't. They come into a gynae office, they come to my office, and you know, they both get a good experience. You know, one is
Right.
learning, the other one is being supported. So it really is a safe space to discuss,
Mm.
you know, everything from sexual health to, you know, whatever. It's a safe space, really.
Right. I love that. I have a couple of friends who are actually in their 30s that have never been to a gynecologist, and they're sexually active. And I'm like,
Naughty.
I'm literally gonna chain you
You're
to
gonna
my
have to
arm
drag
and
them.
take you. Yeah. So important. It is
Oh.
so important. Okay, let's see. What is the next question that I have? What are, so many questions. Um, what are the typical symptoms that, or symptoms, signs that a woman should look out for that indicate that she has an infection of the vagina?
Yeah. Okay, it's a very good question because it's very variable, actually. So the common symptoms of a vaginal infection would be that the woman experiences burning, vaginal discomfort, itching, vaginal itching. Sometimes there is an associated vaginal discharge. And I want to quickly say that a vaginal discharge is normal physiologically. It's usually whitish, sometimes it's light yellow, sometimes in the middle of the cycle, it's clear colored like egg white. But women have vaginal discharge, and this is normal. But when she's getting, or if a woman has an infection, she will notice either the vaginal discharge changes in color, becomes deeper yellow or green. Sometimes it can be blood-stained. Sometimes it has an offensive odor to it. Women sometimes describe this as a fishy odor or a very dark odor that they don't understand. Sometimes they will notice vaginal, just an absence of it, just real dryness that is uncomfortable. And vaginal infections can also present in a slightly different way, which some women need to understand. And that is with back pain. Sometimes you have virtually nothing vaginally, but just constant back pain. And there is no explanation for its sudden onset. It's uncomfortable. You don't know what's going on. It can also present with fever, with just really no symptoms in the vagina at all, just feeling feverish, feeling under the weather, etc. And the last, that's not so common symptom that can happen, is that it can present with your periods getting just mental, very heavy. The periods become extremely heavy, and this is an association with inflammation. So if a woman has, usually it's the end symptom. So if a woman has had a vaginal infection that has not been treated or has been ignored, this inflammation can sometimes spread up the genital tract into the lining of the womb, and it causes a sort of little baseline inflammation in the lining of the womb, which then shows up as very heavy periods. So as you can see, it's a very, very wide spectrum of conditions. I didn't even talk about the bladder and the bowel, because we share compartments as women. We share the uterus, the uterus, the bladder, and the bowel. We are in a compartment. You've got the bladder in the middle, the uterus in the front, and the bowel at the back. So if a woman has a vaginal infection, again, it's usually an end symptom, a late symptom, and it has either been ignored or gone untreated, and there is ascending inflammation. They can present with symptoms that they think they have a UTI. They will just keep going to the bathroom, getting up, getting burning and discomfort, and you check the bladder and it's negative. Maybe it's not coming from the bladder. Maybe it was a vaginal infection. So it's a very wide spectrum, but the commonest is usually vaginal discomfort, irritation, vaginal discharge. Those are the usual symptoms.
And what are some of the leading causes? I remember when I first moved to Dubai, I was traveling a lot. I was constantly going from here to Italy, here to France, like all over the place. And after every single time I traveled, I'd come back and I'd have a vaginal infection. And so what are some of those common causes that a woman can point out?
The leading cause, honestly, is a fungal infection. It's called Candida, candidiasis. Now, Candida is an innocent bug, actually, when you think about it, when you compare it to all its cousins and everything else that can happen. But it is the leading one. Candidiasis is a problem. Candidiasis is a fungal infection where if there are predisposing factors, and those factors include, very similar to what you've just described, traveling, sleeplessness, insomnia, your diet goes off, you're forgetting that everything, you just need to eat quickly and get on with what you're doing. Sometimes if a person changes their lifestyle and their exercise regime falls off, etc. These are the sometimes very innocent causes of Candida, and it causes there's a slight change in the vaginal pH, and out comes this thick white cheese-like discharge that just causes so much irritation, and the woman has got to take some treatment. So that's the first, actually. Of course, Candida can be caused by some much more serious conditions, things like polycystic ovaries, actually. A woman who has PCOS, a patient of mine a long time ago was diagnosed with polycystic ovaries just because she kept on coming back with recurrent candidal infections.
Oh, wow.
Until I decided, right, I'm going to check your insulin, your fasting insulin. I'm going to do I'm going to look for your impaired glucose. I'm going to scan you, see what's going on. And we found polycystic ovaries and insulin resistance. So Candida can also mask that. It can mask diabetes. Candida can mask underlying problems that are changing your metabolism, and the woman just presents with recurrent vaginal infections. The second commonest, I have to say, is bacterial vaginosis. Now, bacterial vaginosis, BV, everyone knows about this one, and it is true. It's a very common because it's a bug that they normally inhabit the vagina. They are supposed to be protective. Gardnerella, Bacteroides, these are supposed to stay and protect the vagina. But under the right circumstances, again, similar circumstances that you described, where women are very busy, they're not eating properly, they're not sleeping properly, they wear the wrong underwear, whatever causes, antibiotic use is another issue. This can make an overgrowth of either Gardnerella or Bacteroides, or any of the Candida, like the bacterial vaginosis bacteria. And it causes annoying symptoms. It causes burning, discharge, a fishy odor. Women are actually quite worried, and they think that there must be something terrible going on. And again, presenting to a gynecologist, will take a swab, will understand what's going on, and will give you the right treatment for it. And also we'll look at preventive measures so that it doesn't keep on coming back. And those preventive measures are not medicines. They have to be lifestyle, so that it doesn't keep coming back. And then, of course, the others are not so common as we go down the tract. Things like trichomonas. These are more of the sexual transmitted diseases. They can sometimes cause vaginal infections, but they are, by most account, they are not the commonest cause. And this is what we need to get out there. Women who get a vaginal infection, the least likely cause is a sexual transmitted disease. The most likely cause is going to be Candida or bacterial vaginosis, which can happen even if they're not sexually active.
Right.
So it's really interesting to note that it's not all STD screening if a woman gets recurrent vaginal infections.
Right. And I think it takes the shame piece out of it. Like it can very much be your diet, your lifestyle. It could very much be cured diet and lifestyle. Yeah.
Absolutely, man. And that's usually the primary cause of these problems, really.
Right.
And in the younger girls, the netball players, the very sporty young girls, they get a lot of infections, really, because of lifestyle, nothing more. So, and in the older woman, the woman who's over the age of 50, they're going to get vaginal infections, not usually because it's a big problem, but usually because of Candida and because of lack of estrogens. When the estrogen level drops, the vagina becomes much thinner, much drier, and it's very easy for them to get injured and then get either through sexual activity or even just nothing and still get an infection. So it's very prevalent.
Okay, that was great. Such an important, I feel like so many women go through it. So that was so helpful. I just have one more question, and this is largely around the topic of HPV. HPV obviously is something that I am very familiar with and that I had for a very long time. And I know that there's still so many questions around HPV, but one of the questions that we get a lot is around the vaccine. And I know that the vaccine has just recently become available here in Dubai or the UAE. But women want to know, when would you recommend getting the vaccine? Who would you recommend the vaccine for? And is it something that you have to take multiple times throughout your life? Is it a one-time thing? How does the vaccine work?
How does it work? I'm so glad you asked that. HPV is close to my heart.
So many questions.
You're so lovely. No, but I love it. They're all very, very good, valid questions. So, cervical cancer. I'm going to start it from the other end. Cervical cancer should not be happening. We should have eradicated cervical cancer, really. And one of the reasons why we still have cervical cancer with us is, again, education. It's about awareness. It's about what to do, how to manage, and prevention, basically, preventive, measures. So HPV vaccination is the other spectrum, is the other end of all our cancer screening and our cancer awareness, activities. It's kind of culminated in HPV vaccination. And this is because this research is not new. I'm 28 years in the business, and it's been around for at least 25 years that we've known that human papillomavirus is the cause of 99.7% of cervical cancers. Therefore, if you work back and you think, well, if I can prevent a woman from getting human papillomavirus, then they'll never get cancer. That's where it all started. And human papillomavirus is a ubiquitous virus. It's everywhere. It's on our clothing. It's on the desk. It's everywhere. So everyone is going to be exposed to human papillomavirus. It is a myth to say that this is related to activity or whatever. It's nothing. We will all be exposed to it. And therefore, if you can get a vaccine that will prevent a woman from getting the disease, if she's exposed to it, again, that's where your answer lies. Now, I really want to quickly say that even if you're exposed to HPV, you have an 85% chance of getting rid of it. Your body will mount a massive immune response and get rid of it. And only 15% of women are going to be left with lingering HPV. And that's the group that we have to capture. Right. And so it is so important to capture, to have the HPV. Human papillomavirus is a vaccine, is a vaccine that looks at, looking at there are actually 9 high-risk oncogenic types. There are about 130 HPV viruses, but we are actually focusing the vaccine on just 9 of them. There are 2 types of vaccine. In fact, there are 3 types of vaccines. You've got the bivalent, which only has 16 and 18. You've got the quadrivalent that does 16, 18, 35, and 36. And then you've got the nonavalent, which is available actually not in Dubai or the UAE. It will soon become available, but it's available in Australia and Japan, etc. These vaccines, they will prevent cancer if given at the right time. And this is your next question. 12 to 16-year-olds who are in secondary school, who have not gotten married, they're not sexually active yet, this is the right time to capture them. And I would go on to say that it's not just the girls. I think the boys should be vaccinated too, between the ages of 12 and 16. And that will give you a big cohort of protected individuals. Now, after that age group, assuming a woman comes to a gynecologist and just wants to have a pap smear and just wants to have, just wants to know, what is my HPV serotype? Have I been exposed to this? This is so important. This is what women should be asking for. You do a pap smear, it's negative. You do a HPV serotype, she's negative, she's not got lingering HPV, or she's never been exposed to it. She's the precise person that you need to do to give HPV vaccination to. And this can be at any age, absolutely any woman, because remember, the vast majority of women who are exposed to HPV are going to kill it. So the vast majority of women who have been exposed to HPV will not have it. So they should be vaccinated, particularly if they have negative pap smears. Now, the next question you asked me was, what is the vaccine protocol? How do you give it? And how long are you going to have it for? HPV vaccination is given as 3 shots over 6 months. And it's given once. You don't need to repeat it. Once you have completed a course, you don't need to repeat it. It gives you lifelong protection against HPV. One of the beauties of having HPV vaccination is that the usual cervical screening protocol is that young women are screened from age 22 to 21, depending on what country you live in, right up until they're age 60. They're screened every 3 years, 2 to 3 years. But if you have vaccinated yourself and you know that you've completed a 3-dose, 6-month vaccine course, you don't need to be vaccinated to be screened so often, because the chance of cervical cancer in this group of women is small. So you can increase the interval of screening. And these women can be screened every 5 years, sometimes even every 7 years. And they will still be safe because they've been vaccinated. And it will just cover the small 0.3% of cervical cancers that are not related to HPV. Is the vaccine safe? The vaccine is incredibly safe. Is it painful to have? No, it's not. It's got the same vaccine precautions that we give with any type of vaccine, i.e. if you're allergic to eggs or proteins, you've got to let us know, etc. If you have a fever, you shouldn't really take the HPV vaccine. But other than that, and also we try not to give the vaccine during pregnancy because of the length of time it takes. And we give it just after the woman has had her baby or just before. But I am such a believer in HPV vaccination. I think that if we could reach even, I would say something like 70% HPV vaccination rates in countries all over the world, particularly in the developing world, where there's just so poor access to
Right.
women like us, platforms like this, you would be able to eradicate cervical cancer. And cervical cancer is a disease of young people. It is not something that you should take for granted, because it is our youth that are being affected by this. So 100%, Emaan, I am so for HPV vaccination. And there is a lot more to tell you about it, but time doesn't allow me to. But it is a good one to have, and it is safe to have, and it protects you lifelong,
Amazing. Yeah, I've actually just recently signed up to get my vaccination. I had HPV for close to 9 years, and by the time my body was able to fight it off, it led to cervical cancer for me as well, and I had to go through 2 rounds of cryosurgery, and I still had irregular cells and HPV for up to 9 years. And
yes.
when I had first moved to Dubai, this is about 5 years ago, that was my first normal pap. And so I haven't had the opportunity to get the vaccine, where now I do, and I'm definitely going to get it.
Come to my office, I'll give it to you myself.
Yes, I would love that.
I'll give it to you myself, definitely.
Okay, I would love that. I'm definitely signing up for that. Oh, Dr. Mariam, thank you so much. This was
Emaan, what a pleasure.
So helpful. I cannot wait to meet you in person. I'm coming to you very soon. If not, if I can get an appointment next week, I'm coming.
No problem. It's my pleasure. What a wonderful thing. And let me take this time to really congratulate you for everything that you're achieving. Your whole life story is a celebration of what it means to, take control of your life and just move forward with what you really believe in. And it's amazing for you to even be at this stage where you are sharing your story to young women. Honestly, it's amazing. I can't congratulate you more, honestly.
Thank you.
So
Thank you so much.
definitely KETISH, everyone. Look out.
Get KETISH.
You've got to watch that. It's so good.
Thank you so much, Dr. Mariam. I really, really appreciate it. I'm going to stop the recording.